Hi everyone. Thank you very much for coming. Thank you very much for coming. And thank you, Jason, for taking the train and coming here. And thank you, Nicky, for joining over the web. So we're very happy to have both of you here. And Casey and Daly is scientific coordinator, on the NICE Guidance Technical Support Unit at the University of Bristol. At the same time, she's doing her PhD at McMaster University. And Nicky Welton is a professor of statistics and health economic modeling in University of Bristol. And she's the director of the NICE Guidance Technical Support Unit. So thank you both for coming to discuss the non-parametric approach for combining evidence of progression-free and overall survival. Looking forward to hearing how we should be doing it. So thank you very much.
Well, thank you so much.
I forgot to ask whether you want to have the questions during or at the end.
During is completely fine. Yes.
And Nicky, you can hear us?
I can hear, yes.
Great, thank you. Okay, so thank you very much for the invitation. As Petra said, Nicky and I work as part of a team at the University of Bristol that provides technical support to NICE guideline developers. As you may know, NICE is the National Institute for Health and Care Excellence in the UK, and the treatment recommendations in their guidelines are often informed by the cost effectiveness of treatments under consideration. In this talk, I am going to present a framework for combining survival data across trials that compare cancer therapies. This framework aims to overcome some limitations of existing traditional approaches for combining survival data, which were not appropriate for a data set that we recently worked on in a NICE guideline on non-small cell lung cancer. Throughout this presentation, I will be making use of that data to motivate and illustrate the proposed approach. So to measure the health benefits of cancer therapies, economic models require estimates of the mean progression-free survival time, as well as the mean post-progression survival time. And these times may be estimated by the area under their survival curve. If we turn to cancer trials to provide this evidence, we instead typically see them providing evidence on progression-free survival and overall survival. However, this is still okay because we can derive the post-progression survival time as the difference between overall and progression-free survival. When there are multiple randomized control trials providing relevant evidence for the economic model, the relative effect from these studies should be synthesized. And when there are two or more treatments, this is often done through a network meta-analysis. So to briefly describe what a network meta-analysis says, I'm going to make use of the evidence in that non-small cell lung cancer guideline. The guideline developers have found 6 trials that provided evidence on 2 of the 3 treatments of interest. So these were chemoradiotherapy, chemotherapy plus surgery, and chemoradiotherapy plus surgery. Okay, and I'm going to sometimes refer to these as CR, CS, and CRS respectively. So as you can see this mouse, each trial provides direct evidence on the treatments it compares, and these relative effects form a network of evidence on those 3 treatments. If we recognize this as a network of evidence, we can indirectly estimate the relative effects between 2 treatments through the trials that compare these treatments to a common comparator. And we can do this using this equation down here. So for example, if we know that the relative effect of CRS versus CR is 5, and the relative effect of CS versus CR is 2, then the relative effect of CRS versus CS must be 3. Okay. We can then take that indirect evidence and combine it with the direct evidence on that relative effect from the head-to-head trials in order to hopefully come up with a more precise estimate of that relative effect. So in summary, network meta-analysis combines direct and indirect evidence subject to this constraint. And in the end, it will give us a pooled set of coherent relative effects. And we can rank these treatments based on this coherence and of relative effects. Okay. So traditionally, when we pull evidence on survival data, the NMA is typically performed on hazard ratios for progression-free and overall survival separately. Not only does this ignore the relationship between progression-free and overall survival, it also makes the unreasonable assumption that hazard ratios must be constant over time across trials. So when we looked at the Kaplan-Meier curves that were going to inform this guideline, we noticed that the curves crossed at least once for both progression-free and overall survival across every single trial. So for this particular set of data, the proportional hazard assumption was unreasonable. So to avoid making an assumption regarding proportional hazards, we could instead model the parametric distributions of these curves. However, for this particular data, we observed very diverse shapes, and it was unlikely that we could find a common distribution to model these different shapes. For example, here is an example where the 4 trials studying chemotherapy plus surgery, especially with the overall survival, we can see that one is concave and the other is convex. So in light of these limitations of existing traditional approaches, our objective was to derive and today present a non-parametric approach, which jointly synthesized the relative effects from progression-free and overall survival Kaplan-Meier curves. We wanted an approach that did not require any parametric assumptions, did not require that constant hazard ratios assumption, respected that relationship between overall survival, progression-free, and post-progression survival, and ultimately provides us the input required for an economic model. Okay. So traditionally, network meta-analysis is often performed on aggregate data. However, when a trial presents a Kaplan-Meier curve, we can extract the synthetic individual patient data by digitizing these curves and using a validated algorithm. So on the right, I have a table which gives a sample of what this synthetic individual patient data must look like. We can see that for a patient on treatment 2, they experienced a progression event at 0.0318 years, and that should correspond to a drop on the curve for that particular treatment. Having this more enriched data set allows us a lot more opportunities in terms of analysis. And we saw that in that guideline, all the trials had reported Kaplan-Meier curves for both progression-free and overall survival data. So we extracted the synthetic individual patient data from those. We then took those synthetic individual patient data and replotted the Kaplan-Meier curves. Note that if it is of interest to you, that we were able to reproduce the summary statistics in these trials using that synthetic individual patient data. So that gave us more confidence in the validity of the results. So then we can take this individual patient data to the Kaplan-Meier curve and estimate the area under the curve. This has been suggested in the survival literature to be a sufficient parametric outcome measure, and it also gives us the input we need for an economic model. Note that when we're comparing two treatments, the difference between the areas under their curve can be taken as a measure of relative effect, and this may be interpreted as the mean gain in survival time associated with the better treatment. All right, so because progression-free and overall survival data are related, we jointly modeled the trial data using a bivariate normal likelihood. Okay, and what this requires is the restricted mean progression-free and overall survival time, a measure of their corresponding standard error, and a measure of the correlation between progression-free and overall survival. To estimate the restricted mean survival time, I've mentioned that we estimated this using the area under the Kaplan-Meier curve fitted to the synthetic individual patient data. And this, along with the corresponding standard error, can be obtained in most standard statistical software. So, for example, for this guideline, we use the surrogate function of the survival package in R. In terms of the correlation between progression-free and overall survival, this is a little more complicated to obtain, especially when dealing with synthetic individual patient data. So in order to estimate this, we used a non-parametric bootstrapping technique of the synthetic data, applied to the synthetic data, and we made sure we only kept bootstrap samples where the overall survival curve was greater than or equal to the progression-free survival, because that should be true by definition. Okay, so to explain this non-parametric bootstrapping technique in more detail, if you imagine we have two sets of the synthetic individual patient data, one for progression-free and the other for overall survival. What we did is we sampled with replacement from these two data sets independently for each treatment of each trial. And then for each paired bootstrap sample, we checked the Kaplan-Meier curve to see if the overall survival curve fell below the progression-free survival curve. If that happened, then we would discard that sample and keep going until we made sure we got some paired bootstrap samples that met that constraint. So here's an example where the overall survival curve is always greater than or equal to the progression-free survival curve. For this particular pair of bootstrap samples, we would keep this data and then record the area under the Kaplan-Meier curve. Where those paired bootstrap samples have a Kaplan-Meier curve at the overall survival falling below the progression-free, we would discard that and keep bootstrapping until we had a pre-specified number of paired bootstrap samples that respected that constraint. Okay, so in the end, you might end up with, say, 5,000 paired bootstrap samples for the progression-free and overall survival. We have the areas under those curves, and then to estimate the correlation, we took the correlation between those paired bootstrap samples. Okay. So that gives us what we need for the bivariate normal likelihood, and the data is inserted into the synthesis model in terms of progression-free and overall survival. So if we let theta be the area under the curve or the restricted mean survival time for the treatment in arm K of trial I, we can then specify that relationship between overall survival, progression-free, and post-progression survival, and then that would allow us to place the NMA models on progression-free and post-progression survival separately. And these are, we do this because these are the endpoints we need to inform the economic model. Okay, so I'll first describe the model focusing on progression-free survival. So we can assume that the treatment effects act in an additive way. So in that case, the mean restricted survival time for progression-free survival in the treatment of arm K of trial I is equal to the restricted mean survival time in the baseline arm of that trial, plus the difference between the two. I can explain this in a less technical way. If we think of restricted mean survival time purely in terms of the area under the curve. So again, if we are comparing two treatments, we have two hypothetical progression-free survival curves. The area under the curve for the treatment in arm K is equal to the sum of the area under the curve for the baseline treatment plus the difference between the two areas. So that's all that equation is saying. Okay. So these differences in the restricted mean survival time or the area under the curve are our relative effects. We can place a fixed effects or random effects model on them. The random effects model allows there to be between study heterogeneity in the relative effects if there is the presence of that. So what we say in the fixed effects model is that the mean difference in the restricted mean survival time is equal to the pooled relative effect of treatment K versus a reference treatment in that network, minus the pooled relative effects of that baseline treatment in that trial versus the reference treatment. Okay, and this is where the consistency equations come in that I described much earlier in this talk that allows in order to pool direct and indirect evidence. Okay, so that's the model for progression-free survival, and a similar model is placed on post-progression survival, and it looks exactly the same. The only thing that would change are the superscripts in this notation. Okay. So that's the additive treatment effect model, but because survival time is skewed, it might make more sense theoretically to place a multiplicative model on it so that we're modeling the relative effects as ratios rather than differences. Okay. So it looks like this, not much different from the additive model. The only difference is that we model the effects on the log scale. So the log area under the curve for treatment, the treatment in arm K of trial I is equal to the log area under the curve in the baseline arm plus the difference between the two. So the NMA will give us the pooled relative effects. If we're working with the additive model, we have the differences in progression-free and post-progression survival time. And if we are working with the multiplicative model, the relative effects are the log ratios of the restricted mean progression-free and post-progression survival time. Okay, and you can think of those as the difference between the log means. Okay. The economic model, however, requires measures of the absolute treatment effect rather than the relative effects. So we need the mean area under the curve for each treatment. We can obtain this if we assume mean progression-free or post-progression survival time over a restricted time period in a population of interest. So let's call that mean PFS for the reference treatment. Okay, we can take that assumed effect and apply it to the relative effect in order to obtain the absolute measures of effect, so the restricted mean survival time for each treatment. So for example, if we're working with the additive model, we are pooling mean differences. We simply add that assumed effect to the mean difference, you will get the absolute restricted mean survival time for a particular treatment. Okay, and we can similarly count the mean time spent post-progression in a similar way. Is there any questions about that so far? Yes.
Do you have to take, like, you're calculating the area under the curve in a non-parametric way, so do you have to take, like, the shortest time of the trials that are available, or is there some way to, like? Yeah,
that's a very good question. So for this approach, you have to make sure you have the same restricted time period over all the trials to pull the results. So for our particular data, the longest common follow-up time in the trials was 5 years, so we restricted the time period to that. Any trials that had a longer follow-up period, unfortunately, we had to truncate the curve to that time point.
There are other, sorry. There are other options available. I mean, in this case, we had 5-year follow-up for nearly all the studies, but one only had 4 years follow-up, I think. And we did consider the option of where we had 5-year follow-up, looking to model jointly the 4-year and the 5-year follow-up, and then use that as to be able to infer the 5-year follow-up from the 4-year follow-up in the trial where we didn't have it. So that's an option.
Yeah. Okay, and it is an area of future work for us as well. I'll talk about that more later. Okay, so another potential thing or step that might be required to get the required input for an economic model is that we need to implement a discounting on the health benefits. So at NICE, they like to discount the health benefits to reflect the preference that we want them to occur sooner rather than later. Okay. This needs to be done before we input the data into the NMA model, because what we need to do is we need to cut up the area under that curve into 1-year time intervals, because we're applying a yearly rate. and we just discount the areas under the curve for each interval using this equation. So in the first time period, that area is not discounted, and then the subsequent areas in those time intervals are. Okay. So that gives us, the sum of those discounted areas gives us a total discounted area under the curve. But we also need to now get the standard error of these discounted areas in the curve as well as the correlation. So that's not quite straightforward. So we went about estimating this using the same non-parametric bootstrapping technique that I described earlier. Okay, so here is an example of the data set that we ended up with. So for each trial and each treatment in the trial, we have the discounted areas under the curve and their corresponding standard errors, and then a measure of the correlation between PFS and OS for each treatment. Okay. And as you brought up that great question, these areas in the curve are truncated at 5 years. So to implement this approach, we ran the NMAs in a Bayesian framework, and this required us to place priors on the parameters that need to be estimated. So for the baseline and treatment effects, we gave them a non-informative prior, and where we estimated or fit random effects models, a bag prior was given to the between study standard deviation. Okay. We fit both fixed and random effects model and compared their fit based on the posterior mean of the total residual deviance, as well as the deviance information criteria. In a similar manner, we fit the additive and multiplicative models and compared their fit. So when we fit these models to the data, informing that lung cancer guideline, we saw that both the fixed and random effects models fit the data equally well, and there were no meaningful differences in the deviance information criteria. So we decided to go ahead and base the results on the simpler fixed effects model. In terms of the fit of the additive and multiplicative models, we didn't see any meaningful differences. So in the next couple of slides, I'm going to present the results for both, discuss the merits of whether we should go for an additive or multiplicative model. So here are the relative effects of CS and CRS versus CR. On the left, we have the relative effects outputted by the additive model, and they're interpreted in terms of differences. Here are the exponentiated relative effects, so instead of log ratios, they are ratios, and these are outputted by the multiplicative model. The key thing to note here when looking at these effects is that both models produce similar relative effects. For example, both models suggest that CRS is more effective than CR in improving progression-free survival because the credible interval does not cross the line of null effect. It might be easier to also look at the absolute effects to compare the estimates. So once we assumed an absolute effect and applied that to relative effects, we got the mean progression-free survival time as well as the mean post-progression survival time. So within each outcome, we have the estimates from the additive model and the multiplicative model for each treatment. And again, the point estimates and uncertainty are quite similar for all of these, with the exception of the estimate for CRS, post-progression survival time. The additive model estimated this survival time with much more uncertainty compared to the multiplicative model. In terms of interpreting this, we don't see much difference in the absolute effect apart from the progression-free survival time for CRS, which seems to be improved by that treatment compared to the other treatments. Yes?
On the multiplicative model, do you exponentiate the result? Do you need to adjust for the fact that you log transform and then exponentiate back to?
Yeah. So when we combine the assumed baseline effect with the relative effect, that'll have to be done on the log scale, and then we exponentiate those in order to get the mean progression survival or post-progression survival time on the natural scale. Any other questions at this point? to briefly summarize, we have presented a simple non-parametric approach that allows us to jointly model the progression-free and overall survival data in order to provide the input required for an economic model. We saw no differences, no major differences between the additive effects and the multiplicative effects, but on a theoretical basis, it might seem more reasonable to fit the multiplicative model because survival time is skewed, so the treatment effects should be modeled as ratios. This approach can be extended in order to obtain further economic inputs that may be required. For example, the time horizon in those trials might be much shorter than what you need for the economic model. So what we can do is we can take that area under the curve for that restricted time period and add it to the area under the curve obtained from external data. So for example, for progression-free survival, we have this restricted time period, the area under there, estimated by the trials, which is this bit here. And then we can find an appropriate external data set that provides evidence on the area under the progression-free survival curve. But we want to make sure we're conditioning this area under the curve from that external data set on the patients that have survived up until that truncated time point. In terms of how we might be able to do this in terms of post-progression survival time, for this particular data set on non-small cell lung cancer patients, it seems reasonable that of those patients who survived up until that restricted time period of 5 years, those patients who haven't progressed could be considered cured, so then they would no longer experience a progression event other than death. So then in that case, the mean post-progression survival time for the whole time horizon would just be equal to the mean post-progression survival time in that truncated time period. And empirically, we could see that this assumption was reasonable for our data set because when we looked at the Kaplan-Meier curves for overall and progression-free survival, we saw that the overall survival curve tended to converge with the progression-free survival time at that time point. So we have shown how the discounted areas under the curve can be estimated so that the resulting restricted mean survival time can be used to incorporate discounting for a prediction survival model without making any parametric assumptions. However, the model may also include some one-off costs. For example, a patient might progress and then we need to incorporate the cost of additional tests. This requires estimates of the proportion of patients progressing in each 1-year time interval. So we can also estimate this without parametric equations by synthesizing the evidence on 1-year conditional survival probabilities in a separate network meta-analysis. So as we briefly touched on this before, this method works great when all the trials are presenting similar follow-up tests or a sufficiently long follow-up time period. However, it's not quite clear, or we have to work on this, what to do when, say, we have lots of trials reporting at least 5-year follow-up data and then one trial reporting 2-year follow-up period. It wouldn't be wise to probably ignore that, so we have to think about how we would go about using that data and extrapolating it for the remainder of the time horizon. So that's an area of work that we would like to look into in the near future. If anyone has any suggestions, we're very happy to hear them. So here are some key references. If you're interested in the formula and the code for this model, it's in that lung cancer guideline here in Evidence Review C. So you can see it there, and we'll hopefully publish the work sometime this year. Thank you.
Last and final question. Thank you very, very much. Yeah.
So thank you. I want to go back at a conceptual level to handling the post-progression state, because when people progress in the oncology world, they're often subjected to subsequent therapies. And so in each of the trials, for example, that you're going to try to combine in your network meta-analysis, they will have an initial treatment, a time period where they're not progressing, and then they'll have a post-progression period. But during that time after they progress, they may get one or more subsequent therapies. They're rarely just getting supportive care, palliative care, and dying. And so how do you think about those different subsequent therapies? Because it's a huge issue in many of these analyses where in the oncology world, again, they're presenting PFS as the primary endpoint, and yet so many of these people get secondary therapies. And so then the whole question of what is overall survival and how meaningful is it, and there are arguments in the oncology world. But in this case, how do you handle that, particularly when your individual studies may have been at different periods of time, and so then the subsequent therapies may have been available at different time points? So how do you look at the heterogeneity in your mean PPS versus your PFS?
I think that might be a good question for Nicky, hopefully, on secondary treatments, how to incorporate it.
Yeah, no, it's a good question. I think what we're modelling is the relative effectiveness. So we're looking at the difference between the trial arms in post-progression survival. So the question is really, were the treatment options that were available post-progression in one arm the same that were those available in the other arm? And if that's the case, then the differences between those arms are really driven by the first treatment. So so that's the assumption. Of course, some studies allow those on, say, the older treatment to cross over and switch onto the newer treatment post-progression, and then you've got biases entering into the results. So because we're looking at relative effects between the treatment arms, and hopefully in a trial all patients have had the same options post-progression, it shouldn't be too much of a problem. It's only the situation, I think, where you've got differences between arms that we really have issues.
Thank you.
Yes.
Thank you. This was a very interesting concept. I'm a cardiologist clinically, and to me this seems an attractive way to study, cardiology models where we also use a lot of surrogate outcomes. But the difference is a lot of cardiac events are recurrent, right? So for example, think about a heart failure trial may look at heart failure hospitalizations, which can happen 3, 4, 5 times a year for the rest of the patient's lifetime. Could this model be adopted to take into account recurrent events as opposed to cancer progression, which we tend to treat as a one and done?
Yeah, if we model time to events and it recurs, I'm not sure if there might be a better way of doing it other than this approach. Nicky, do you want to comment on that?
Well, the subsequent model, when you have recurrent events, is often modelled with a Markov model, and in cardiology, I know they have quite complex models where the chance of having a subsequent event, if you've already had one, is different if you haven't already had one, and it might be different if you've already had 2, and so on. So actually, there's quite complex relationships between the multiple outcomes. So I think some of the ideas may apply, but I think it's more complicated.
Yeah. Can I ask on the kind of an irrelevant topic though? You could possibly have a third, progressive state that you might be modeling in that way. Could you say progression 1, progression 2, that? Like, if you're going forward only, could you be able to do that?
Yeah, if you have evidence on those 3 progression events.
Conditional on progression 1.
Yeah. We would just partition the area under the overall survival curve into those different progressions.
Yeah. Correct. So it could be like, heart failure 1, heart failure 2, and then,
Yeah. But I think, I think it might become more complicated.
Yeah.
Other questions? Can I ask one more?
I did, but it was like quite far back. So go.
Okay, I'm gonna also go far back. So, I was curious if you could go back to the bootstrapping that you used to model jointly the 2 of OS and PFS.
Sorry.
Oh,
I hope I didn't stop it. There we go.
is that, like, this is, to me, it sounds applicable to problems beyond the one that you are tackling now.
Estimating correlation?
Yeah.
Yeah.
And have you tested whether this is recreating like if you were to generate data that they're correlated, use this approach to reconstruct essentially the correlation structure, does it work?
Yeah.
Can we borrow that?
We haven't tested that, but that sounds like a good simulation study that we should conduct. Simulation study.
Yeah. Like, my concern with these kind of approaches where bootstrapping restricts some of it leaves out some of the sets. I don't know how much does that affect the.
But I mean, it's inducing, like, the correlation, because otherwise you would just get zero, like, because your samples would be random.
Yeah.
But
So
I mean, does it reconstruct the mean though? You should have, if you were to calculate the restricted mean for PFS and OS, it should be the same, right?
Yeah.
It's the standard error. That's what impacted.
Because you leave out some of the pairs, but then could you be leaving always the lower pairs out or the higher pairs out, and that would affect the mean?
Yeah, I guess it depends how fast the curves go down.
Yeah.
Hopefully, same thing with replacement would make sure that there was
It
enough
happens
variation.
randomly, but if it doesn't happen randomly, maybe.
And yeah, it's something worth checking. Yeah, I think I'll put that on the list of things to do.
Okay.
Thank you. Yeah.
And is there any way you can use that to, sorry, Nikki.
Thank you. Do you want to say something?
Well, I was just going to add to that bit. I think we should have to acknowledge that although we're capturing some of the correlation between OS and PFS restricted means, it's only the part that's due to the fact that there's that constraint there that OS has to be greater than PFS, because you don't have the individual patient data with the pairs of OF and OS, PFS and OS responses for each individual. We're not capturing totally all of that correlation. Yeah. That's
Good
Well,
point.
I was going to say, can you do something to get an understanding of your uncertainty in your correlation estimates and put like a prior on it?
Yeah, that's a good way to incorporate additional uncertainty.
And like the information as well, like you might know from like a study where you had the data like 20 years ago that the correlation was like 0.6. So you could be like, okay, from here I'm getting 0.3, but I also know that I should put some weight on 0.6 and somehow spread your uncertainty.
Yeah, that's a good way to empirically drive informative practice. Yeah, that's a good suggestion. Thank you.
I have one more question if no one else has a question. And that's,
One
yes.
quick question from me. Is this model applicable to the observational data as well?
Observational. So typically when we're pooling relative effects, we want them to be from randomized control trials. Technically, we probably could, but we'd have to be worried about biases induced by the observational data. Do you want to comment on anything else, Nicky, regarding that?
no, that's a good answer. But the only thing is that we did use observational data to do the extrapolation beyond the 5-year follow-up. So we took that from the SEER database, didn't we? I think, which is
Thank you.
And in fact, I think that that's possibly the answer to the question about how do we deal with different follow-up times, is to try and extrapolate each curve first before then doing the synthesis.
Extrapolate as in through external data or through parametric forms?
A combination of
to the
both,
non-parametric.
actually. Yeah.
Ideally, we'd like to stick with non-parametric approach, but
So we, in a situation where you have information that is from a Kaplan-Meier curve up until time t equal to 4, but evidence from the paper that indicates an event, number of events at t equal to 5, but no evidence from the THETA curve. I assume you would be able to make an assumption about what's happening between 4 and 5, so that you can reconstruct the 4 and 5 without having a Kaplan-Meier curve.
that seems possible. Nicky, do you want to comment on how we might manage that?
If I understood the question right, so I mean, what typically they do is to fit a whole range of different survival curves and get a whole range of different extrapolations. And then they use observational data to look at the validity of the long-term extrapolations to try and get some sort of face validity. And maybe you could even use the external data to help with that extrapolation. So is that what you're asking?
Yeah, no, I mean, so we've run into situations where the Kaplan-Meier curve runs until time t, but then in the paper or in the appendix, they would report until time t plus.
Oh, okay.
So I wonder whether you have thought of how you could, use that kind of additional bit of information that sometimes is reported just as in the form of X amount of people survived until 180 days, or like, would you be? I'm just thinking, like, if you needed to get to the same time point, could you use that kind of information that's beyond the Kaplan-Meier? You probably could.
I think we could.
Yeah, I think so. Yeah.
Go ahead, Nicky.
Well, now I was just agreeing. Yeah, I think you could.
Yeah.
I mean, in fact, the method that we use to get the synthesized individual patient data from the Kaplan-Meier curves, that method uses not just where you click on the curve, it doesn't just use that information, it also uses other information that's reported in the paper, like, as you say, sort of survival probabilities at particular times.
Okay. All right. I think, thank you very much. If there are no more questions, thank you.